Hey everybody, thanks for joining me for this month's group coaching for neurofeedback experts. This is niche coaching. Today we are talking about pain, and I am very glad that you are here because I have a very exciting presentation for you all today. So let's get rolling without further ado. Let me pull up my slides and share my screen with you, and we will jump right in. Okay, so hopefully everybody is able to see my slides. I think we should be in good shape. Again, please let me know if you have any questions. We have our webinar chat box. I can see people filing in. I'm glad people are making time on their lunch to join us. The webinar Q&A box will be available. If you have any questions, please put a question in for me. I'm always happy to answer. And if not, remember, this recording will be in our Neurofeedback Expert monthly group niche coaching course in Rizuku, so you can find it there. And I will refer to 3 main studies, but 1 more during our time together today. And there's also links for you. The studies and the links are in the course platform for you, as is this PowerPoint slide for you to utilize, because we need to spread the word. We need doctors to know that there are QEEG brain patterns that are associated with pain. There are neurofeedback studies that show that neurofeedback is highly effective for reducing and eliminating pain. So I need people across this world to know that we suffer with pain on a daily basis, and there is no need to suffer. So let's spread the word, and as we become educated as to what pain actually involves in the brain. You are gonna love this. So without further ado, let's just jump right in. I am going to briefly talk about 3 types of pain today. Acute pain, which is pain that's happening in the moment, how the brain processes pain as it is coming on in a painful experience that's happening moment by moment, second by second. We'll look at that. We will look at chronic pain and why pain processing gets jammed up in the brain and sticks around, which causes higher levels of pain and longer chronic pain. And we're going to talk about fibromyalgia. And actually, fibromyalgia is primarily wrapped up in our discussion on chronic pain, but it is a little bit different in terms of its very widespread pain processing. So, you know, it's being experienced at levels, high levels across the entire body. So we want to keep that in mind, but also we will look at a study that is specifically for fibromyalgia. So that's why that becomes important too. Okay, so let's just jump back a minute and think about the brain and how it processes pain. I am going to share with you the main brain areas for pain processing, and I'm gonna raise myself here, and you'll see that there is what's referred to as a pain matrix, or a connectome as it's most recently being called. And if you look up the research, you'll find that there's been many snappy names over the last 10 years in the scientific literature showing that pain is not just in one area of the brain, it's in multiple areas, and those areas are connected. So I wanted to just remind you what we're going to be talking about just as a frame of reference. So here we have the prefrontal cortex over to the right. I always think it's good, unless you look at brains every day, to remind yourself of this. So we're going to be talking about I'm losing my camera, sorry. We are going to be talking about the prefrontal cortex specifically. We will be talking about the sensory motor cortex, and in the premotor cortex too, where there's a somatic processing area. You can see my cursor there, but we'll primarily be talking about the sensory and this sensory somatic areas of the brain, which are across the central areas, but a little bit more posterior. So keep that in mind. We will be talking about how these areas of the brain relate to midbrain structures, which we are not seeing here, but the thalamus in particular in the middle of the brain. And we'll see it on one of the next slides, I believe. Then in the back, we have visual processing. And I always like to remind people of the speech and language areas, Wernicke's for understanding speech, Broca's area for speech production, auditory processing cortices. So let's move on. And this is the image that I was just referring to. Is you can see how this orange structure right here in the middle of the brain is the thalamus. It receives pain signals from the spinal cord and relays them to higher brain regions. Those that we just spoke about, the somatosensory cortex, so across the sensory processing cortex here, another more midbrain area that registers pain and also unpleasant feelings or sensations is the anterior cingulate gyrus. So if you've been on other webinars with me, you know that this area is implicated and is very hot in addictions. So this is the hamster on the wheel. It's also accessed through the prefrontal cortex this way, and I'll remind you in a second how so, but this is an area that is like the hamster on the wheel, Dr. Daniel Amen always calls it. And when it has too low of excitation, it's not stimulated enough, it looks for stimulation. And when it's overstimulated, it just keeps cranking. So we're really going to think about this in just a few minutes as we think about this prefrontal cortex. And you can see it says processes pain signals rationally and plans action. So it is trying to reduce pain. And you'll see here where mindfulness meditation can really chill out these frontal areas. And this talks about therapeutic approaches, and three approaches were used here. One is in thinking about a loved one, so sending pleasure signals to the pain areas. The other is mindfulness, learning to calm that area down, and cognitive behavioral therapy. So we're not really thinking about those, but that's thinking about a mindful approach to being able to adjust the way that these areas in the brain that process pain are using speed, which we'll get back to our main discussion here. So I just wanted to orient you to a few of the areas that we are going to be thinking about, specifically the prefrontal cortex, the somatosensory cortex here, and how it affects the anterior cingulate gyrus and the thalamus. Okay, hopefully everybody is with me. I don't see any questions, so I think we're okay. In the studies that we are going to look through briefly, you'll see that the main types of pain that we're discussing, and the reason we're discussing them is because this is what has been studied in these studies, is musculoskeletal pain, neuropathic pain, so neuropathies, degenerative joint pain, arthritis, rheumatoid arthritis, which again can be more global, back pain, fibromyalgia, disc pain, intervertebral discs and herniated disc pain, and stomach pain. So it's pretty widespread, and we mostly think of pain as musculoskeletal in nature, but this breaks it down a little bit more for you. And this is what the studies that we're going to look at have really evaluated the most of the types of pain, but you'll see we're going to talk about a couple others also in just a minute. Okay, so types of pain, and let's start with the brain pattern for acute pain processing. And I think this is super interesting, and you will have the reference, I didn't put it on this one, but it's the Montau and Iannetti study, which it's referred to on another slide, so I'll make sure I call your attention to it. But this is acute pain. So let's just think about acute pain together for just a second. Acute pain is, I'm sitting here, and in one of the next slides, you'll see it's fire by my foot. If there was hot pain at my foot, what would happen throughout my system? I'm going to show you the nervous system systemic response in just a second, but in my brain, when there is nociceptive heat, so this is heat pain, this is touch pain, and this is auditory, not necessarily pain, but an auditory stimulus that is unpleasant. And we'll have a discussion about that in just a second. But what we see here is on scalp EEG, which is what we look at, there are very sharp spikes in negative to positive to negative actually, positive to negative use of speed. So there's too much slow speed, or I'm sorry, I'm absolutely butchering this. Let me back up. Here we see, and it's because I wrote it wrong, which I will change that. We see too little use of the proper speed for processing. So we'll just call it SMR or low beta. And then we see excessive use of high beta pain processing speed. So we see these very large spikes in a positive to negative response. So if you think about it rationally or logically, this makes sense. It is the brain jumping from overstimulation to understimulation and back within that acute pain processing experience, and their amplitude spikes. And the interesting finding, so you get the gist of it from high to low, and the interesting finding is that when the heat pain was the most amount of pain, those spikes are even larger than when it was tactile pain versus just an unpleasant auditory stimulation. You can see these spikes are larger. So that is a pretty cool finding. And I'm going to show you more about that in just a minute. What we also see here, now moving forward to chronic pain, and this is really where we are going to live, but I wanted to show you the difference between acute pain and chronic pain, because in acute pain, clearly it is a response. And in the literature, it looks primarily at the differences in potentials, which evoked potentials are not something that many neurofeedback practitioners delve too deeply into when we're doing primarily amplitude training. But you can see that there's large differences in the way that the brain is trying to regulate its use of speed because of having an incident that involves pain. Opposed to chronic pain is there is an actual pattern of pathophysiology. So the neurophysiology of the brain is pathological. It rewires itself so that the brain is not processing like it would in a typical or optimal healthy patient. And that's what it's referred to in these studies that we're sharing right now. And that there is a biopsychosocial approach or factors that are also implicated in pain processing. And I'm going to show you that when we think about pain processing as a network. And we're just going to skim the surface on it because delving into all of the theory behind pain processing isn't fully our goal for today. But understanding that when pain is processed, it is biological in nature because it changes the way that the brain processes information. But there's also psychosocial factors that are affecting biology, and then the biology is going back and affecting the psychosocial factors. And I also have videos on YouTube that talk about the two-way street between our neurophysiology and our psychosocial experiences. So just to give you an example, is that if you are having, and I'm going to clearly bring this back to us in a minute when we think about this, but if you are going through a very difficult time in your life, or if your patient is, let's say, and you're feeling greater amounts of stress and anxiety, which then also culminate in more overwhelm and greater amounts of feeling depressed or in couch mode, that is a psychosocial factor. But we know as neurofeedback experts that that also rolls over, and we can see that in the neurological functioning of people's brains who come into our office. So what does that look like? It looks like too much high beta in people with anxiety, and it looks like too much alpha in people who are depressed, too much delta and theta in people who are overwhelmed and burnt out and are in adrenal fatigue or moving towards that level of fatigue, right? So we see the changes in the brain's ability to use speed well because of the psychosocial factors, and it plays out biologically. So hopefully everybody is with me. So therefore, the findings of the research, and you can see at the bottom it's referred to, and you will have this study in Rizuku available to you in the course platform. The study by Silva dos Santos Pinheiro et al. Showed that at rest, people who suffer from chronic pain have increases in the slower processing speeds. So there's an increase in theta, but the biggest finding was an increase in alpha power at rest. Too much alpha is the culprit. So backing up to some of our other webinars together, we talked about headaches. Headaches tend to also have too much high beta, and we know that that type of pain tends to be from an overexcited brain, but other types of more chronic pain are too much alpha. So that's a pretty interesting finding. Another finding, and this is the way that it's worded, a decreased excitability of the sensory motor cortex. So when we have decreased excitability, it's also too much theta and alpha because, and it does also discuss event potentials, evoked potentials in this study. But thinking about our work, decreased excitability at the sensory motor cortex is too little SMR or low beta. So there's excessive theta and alpha, and there's too little SMR. Another finding is that this is also coupled by excessive alertness. And in the study, it suggests that excessive alertness, AKA high beta, and those are my words, I put them in there, but the study does talk about people who are hypervigilant, which we know comes from high beta, and people whose nervous systems are basically on red alert. Excessive alertness may explain a decrease in alpha power. So alpha, too much alpha power at rest, and then having too much high beta also will culminate in difficulty in processing pain. And I'm going to show you what I mean in just a few minutes on a graph. Okay, so this suggests that, this is a quote from this study, which I love. It suggests that a QEEG could be considered as a simple and objective tool for the study of brain mechanisms involved in chronic pain, as well as for identifying the specific characteristics of chronic pain condition. So it's a simple and objective tool so that we can see what's underlying a specific person's chronic pain. So we know that it's going to involve too much theta and alpha, possibly too much high beta, and not enough SMR or low beta in certain areas that we're going to talk about in just a second. And what this creates is altered perceptual states. So the changes in neural processing will also affect altered perceptual states and vice versa. They will go back and forth. So brain functioning and the behavior are different in brains of people with chronic pain. So long story short, people who suffer from chronic pain actually have different neurophysiology of the way that their brain is using speed. Hopefully we got that, and we're going to move on. Now, moving on to the pain matrix, the areas. What are involved? The areas involved are the anterior cingulate gyrus. So I showed you that on a previous slide, where it's basically accessed in from the prefrontal cortex or from area CZ. It's down in between these two areas. It is that hamster on the wheel. It's considered a frontal structure, but it's more medially, it's more interior in the brain than higher cortex structures. So remembering back to our discussion, if you watched the webinar on tinnitus and misophonia, that our cortex in the brain has pyramidal cells that will go from higher cortical areas on the scalp to more interior areas. And that's how training at the prefrontal cortex, neurofeedback training, or at area CZ can also affect the anterior cingulate gyrus and the thalamus, which we'll talk about in just a second. So we see there's increased slow activity within the anterior cingulate gyrus. There's increased slow activity within prefrontal medial areas. So they're very close to each other, and we will access them from these prefrontal medial areas. And there's also thalamocortical dysrhythmia. And that's a thalamic dysfunction, and many times we talk about it as difficulty in thalamic gating from the thalamus to these cortical areas. And it's a decreased inhibition that increases the firing at 4 hertz. And 4 hertz is theta. And that's how we can have increases in theta that are not only happening from the cortical areas, but are also being perpetuated from these midbrain structures in the thalamus. It's a two-way street. So I guess a saying that's coming out of this webinar, which we never know until we get discussing it, is that when it comes to pain, much of the time it's a two-way street. It's a two-way street between the person's life, their psychosocial state, and how that's impacting their neurophysiology, and then their neurophysiology also goes back and feeds their psychosocial state, two-way street, and from higher cortical areas to more midbrain structures, we have that back and forth going on also. So all of the studies that we're talking about and many, many others that are referenced in the studies that I'm giving you are, there's in the, I believe it's the Silva study. There are so many awesome studies that you can look at that describe this pain matrix and this dynamic pain connectome. But basically all of these studies and all other studies that you'll find show a very similar model of how pain is processed in these different areas together. And here's one quote from a Cucci and Davis study, which is referred right there. It's the spatiotemporal signature of brain network communication that represents the integration of cognitive, affective, and sensory motor aspects of pain. And that's what we just were saying, it's a two-way street. Here for you is a nice pop science reference that talks about this connectome and this pain matrix that you could share with your pain patients. So for all of you who are chiropractors and especially focused on pain, or perhaps a pain management psychotherapist, this is great information for you to be able to think about. Okay, so there's also exciting findings, but in the study, they don't refer specifically to neurofeedback, but what they say is when alpha and theta were decreased and sensory motor excitation, SMR, were increased, that then pain decreased. So for pain to go down, we need to decrease alpha and theta, slower processing speeds, and bump up SMR to create sensory motor excitation and low beta. So basically, we're trying to get the brain to be able to process pain in real time at the proper speed and not too slow and laggy. That's what's happening primarily. And then that sometimes can be coupled with too much high beta that jams it up even more because we have that overdrive kicking in to try to help out. And I know what you're thinking. That's what we've talked about in so many of our webinars. Yes, you're right, that too much delta and theta, depending upon the areas of the brain that are impacted, can create so many of the symptoms that we help people with neurofeedback. Too much theta and alpha. Alpha is implicated in this one much more strongly than in other studies, is at the root of pain, and high beta can jam it up even more. And most people, because they have excessive slow speeds and excessive high speeds, are just not using enough excitation or SMR. And that is our job, is to get people using more perfect processing speeds in the middle, less of these extremes of too high and too low, and get people back to business in the middle. And I was about to go on and on about something, but I will leave it at that so we're not here all day. Okay, so this is an actual neurofeedback study by Kubik and Biedron. You have the abstract in the course that you'll be able to reference, and it shows that pain types of all of these kinds, neuropathic pain, cancer pain, post-stroke pain, post-trauma headaches, tension headaches, and migraines, all decreased for patients with more than 50% reduction in pain, and many of them had complete alleviation of pain. And many of the people felt that relief after 30 sessions, but was rated as good, which is great in the literature, if you know that, by patients after 40 to 60 sessions. And of course, you know, everybody's brain is different. The levels of too much theta and alpha are higher for some than others. The too low of excitation of SMR is higher and lower for some people. So that dictates our 40 to 60 sessions. But of course, that's right on with our neurofeedback expert program between 39 and 50 sessions. And then this is in the literature too, and this was specifically for the headache patients, but that they had to come back every 6 months for a maintenance session so that headaches wouldn't creep back in. And so we know that neurofeedback can really shift the brain into a better brain pattern, and for many people, it will stick. Most people like having a tune-up. Quarterly, people will come in on our Neurofeedback Expert program, but again, showing the strength of a maintenance program. Okay, so what are the neurofeedback protocols for pain specifically? What are they and where are they? What is a decrease in theta and alpha, possibly a decrease in high beta, and an increase in SMR or low beta? Of course, you want to do the QEEG brain map and look for these markers, especially in the areas that we talked about, and we're going to make it real easy. On your maps, you want to look in the frontal areas. You want to look at F3, FZ, F4. You want to look across the sensory motor cortex at C3, CZ, C4, moving back towards P3, PZ, and P4. And you want to look for too much slow speed, not enough SMR, low beta, and that could be masked by too much high beta. Okay, I hope everybody's with me because this is pretty awesome stuff. So here's a graph, and I know many people on this webinar use a different system. The format is just the same as yours. The black line is delta, and you can see it here. You know, all systems use basically the exact same format. The black line is delta, the dark blue line is theta, the light blue line is alpha, which we do not want to see on the top. We want to see it down here. We actually, on this graph, want to see it stacked black, dark blue, light blue, green, yellow. And this is someone who's experiencing significant amounts of pain. We have alpha way up here, and we have delta is up near it above theta, which is atypical. And then we also have it coupled with high beta, which is dragging up the low beta. Okay, but here you can see we start at 20. It's kind of going up, but it has a nice downward trend. And this is session 1. Session 23, it's a little blurry, but you can see that alpha is starting at a lower point. We still have beautiful training. We have delta coming down, alpha comes down, it goes back up, but comes back down. We have low beta crossing over high beta down here with better levels, and we have it crossing over high beta here. We have high beta coming down and low beta going up, low beta above high beta at minute 21, again at minute 23 and a half, again at minute 28 and a half. Beautiful training, and this person was receiving a lot of relief from pain. So we want to reduce alpha, reduce either subsequent delta and theta. High beta is involved, we got to get it down. We want to pop up SMR low beta, and we can see how that is happening across these graphs, which is totally awesome. Okay, so in summary, neurofeedback is highly effective for people who are suffering with pain. There's no need for people to have the duration or the intensity of the chronic pain that they suffer. The solution is in their brain. It's my job to help you understand that so you can help them understand that so that you can help them feel and perform better for the rest of their lives. So I hope knowing that this science exists gives you the confidence and the ability to communicate that with your patients so we can go out and change brains and improve lives. Okay, so if anybody has any thoughts or questions for me, please give me a reach out. I'm always happy to help. And until next month, I hope you're well. Thank you very much.